Hello, I'm Anish.
And I'm Anvith from Thomas Jefferson High School for Science and Technology, and this is our science fair project. When a patient develops a thyroid nodule, which is a dense clustering of cells in their thyroid gland, the patient goes to a doctor and they get screened for thyroid cancer. And the doctor screens them using a fine needle aspiration biopsy, an FNA. And as you can see in the visualization, they insert a syringe and a needle into the thyroid gland and extract cells from the thyroid nodule. And then they image this fine needle aspiration biopsy to make a whole slide image. After imaging the FNA to make the whole slide image, as you can see on this slide, pathologists use the Bethesda system, a number scale from 2 to 6 for likelihood of malignancy to determine how likely malignant the person is. And the issue with this process is that pathologists sometimes struggle to diagnose some patients with thyroid cancer effectively. Let me elaborate on the Bethesda system. Category 2 means benign. Category 6 means malignant. Everything in between is indeterminate, where the doctor does not know if the patient is benign or malignant. In fact, doctors classify 30% of all thyroid cases as indeterminate because they simply don't know how to diagnose these patients. Since they're unsure, they usually conduct surgery just to be safe, but this has disastrous consequences. 62% of these surgeries are completely useless. They do it on people who are benign, who don't even have cancer. And this is a waste of healthcare resources and doctors' times and has many patient costs. In fact, 30 to 80% of thyroid surgery patients have some degree of vocal cord damage, depending on their age, pre-existing conditions, and other factors. 30 to 50% of patients following a thyroid lobectomy, a type of thyroid surgery, develop hypothyroidism. Conducting surgery just to be safe is resulting in unnecessary complications for these indeterminate patients who don't even need surgery, and it leads to surgical complications such as nerve damage, bleeding, infection, and more. These are completely solvable problems and something we tackle in our project. What we have done is find these benign patients who are misdiagnosed and save them from unnecessary surgical complications.
First, we used connected component analysis to isolate hundreds of clusters in each patient's whole slide image.
Now that we isolated the clusters, we have to identify the thyroid cells within those clusters. And to do that, we need cell detection models. And to train any cell detection model, you have to train it on cell masks. Manually generating cell masks takes weeks. We did that in a couple hours, and we did this by building a workflow using the segment anything model, SAM, to automatically generate cell masks and use this to train our cell detection models efficiently. We use the Detectron 2 and YOLO V8 cell detection models to identify the specific cells on a thyroid cluster, and we train these models using the segment anything models, generated cell masks, and the annotation data previously mentioned, and using this to train these cell detection models, such as Detectron 2 and YOLO V8, we were able to specifically isolate the thyroid cells within a cluster.
Using these cell masks, we trained a CNN to predict cellular atypia, and that achieved an accuracy of 99.8% on Bethesda classification 2 and 6 patients. And for indeterminate patients in Bethesda categories 3 and 4, we focused more on predicting cluster architecture. Each cluster can either be macrofollicular, microfollicular, atypical, or a crowded cluster, and we created several ResNet 18 and 50 based CNNs to predict these cluster architectures, achieving accuracies of up to 80%. We ran the cluster architecture CNN on hundreds of clusters per patient and plotted what types of clusters each patient has. More specifically, each axis represents the percentage of each cluster type a patient had. Blue dots represent benign patients and red dots represent malignant patients. And as you can see, benign patients tend to cluster around the bottom left of the graph with a p-value of 0.027. Doctors often send many of these benign patients into unnecessary surgeries because they aren't fully confident in their diagnoses. Our results can help improve the accuracy and confidence of these diagnoses so that we can prevent unnecessary surgical complications in these benign patients. The black dots represent patients with architectural atypia, and the green dots represent patients with cytological atypia. And as you can see, they're very well differentiated with a p-value of 0.005. Knowing this information can help us figure out what type of cancer a patient has. We created a custom support vector machine-based statistical test to validate our results. It works by first getting an AUC score for the current data at differentiating blue and red dots. Then it randomizes the labels and then tries to get an AUC score again and sees how much better our AUC score is on the actual data compared to the randomized data. Thank you.